So, good morning, everyone, and thank you all for joining us. And a special thank you to Dr. Charles Anderson for being here this morning to present on proactive versus reactive wound care in the hospital outpatient department setting. And I'm very excited to hear what it is he's going to talk to us about today. So after the presentation, there will be a short Q&A. So please find your chat icon, and if you have any questions at all, please put them into the chat icon for this call, and we'll try and get through as many as we can after the presentation. And I'll now turn this over to Dr. Charles Anderson, who is the Chief of Vascular, Endovascular, and Limb Preservation at Madigan Army Medical Center in Tacoma, Washington. Thank you so much, and good morning, Dr. Anderson.
Good morning, Monique. As stated, my name is Chuck Anderson. I am a vascular surgeon by trade. Over the past 25 plus years, I've been involved in a limb preservation initiative at Madigan Army Medical Center. Currently, my position is Chief of the Wound Care Service at Madigan Army Medical Center. Our approach is a multidisciplinary approach, so we meet every morning with the team and with residents almost on a daily basis. When we're talking to the residents, we emphasize the importance of proactive care. For example, in the diabetic patient, in order to prevent amputations, you want to catch that diabetic patient early when they have a callus or very small ulcer and do very proactive care to prevent that from progressing to a significant ulceration, a wound infection, or even an amputation. So what we're going to talk about this morning is a technique that allows us to be proactive in the wound care setting. Next slide. Just some disclaimers, a couple of things that are important in there, I think. Like any other tool that we use in medicine, the scanning for bacteria is not a tool that we use in isolation, just like a CT scan. You put that in context of other information that you have on that patient. And likewise, this slide here, I work for the US government, and anything I say today is my opinion and certainly not the opinion of the US Army. Next slide. So when we look at the spectrum of bacterial involvement in the wound, this is what it looks like. We know wounds are not sterile, so there's always some contamination in a wound. When that colonization reaches the level of 10 to the fourth, we know from some outstanding studies that that starts to impede the ability of that wound to heal. Unfortunately, from a clinical perspective, even though that level of bacteria is important, most times that's not clinically evident. Then that can progress on to a local infection, a spreading infection, cellulitis, systemic infection, sepsis, and even death. Next slide. The proactive approach is being able to identify bacteria at that level of 10 to the fourth. So if we can, at point of care, identify colonization at 10 to the fourth, when it does start to have a negative impact on healing, we can be proactive in treating at that level and promote better healing, but also stop the progression to a localized spreading infection, a systemic infection, sepsis, and or death. So early identification at that level. Next slide. Part of what we do in wound care is we screen, for example, for vascular disease, important before we're putting on compression or looking for significant vascular disease that can have a negative impact on the ability of a wound to heal. So the question is, why aren't we screening for bacteria? Next slide. So the reactive way that we deal in the wound care clinic in a traditional fashion with bacteria, we focus on clinical signs and symptoms as an indicator of infection. Many of our patients, unfortunately, don't mount that response until late, and certainly at the level of just colonization of 10 to the fourth, many times that is not evident clinically. Our treatment plan then becomes based on the patient's history, clinical signs and symptoms, and guidelines that we have. Many times, taking that approach, there's a delay in definitive treatment. For example, if we elect to do a culture, we would wait for the results of that culture many times before initiating antibiotics. So the traditional approach, unfortunately, contributes to delayed healing, delay in appropriate treatment, and the potential to develop significant complications. The proactive approach allows us, in addition to the clinical assessment, with a bacterial scan to identify wounds that have 10 to the fourth bacteria or greater. We know if we can identify that early and treat that appropriately, then that will have an impact not only on healing, but also can prevent that progression to more serious infection complications. Next slide. So this is the tool that we're talking about for those of you that may not be familiar with the MolecuLight. This is a fluorescence scanning device that allows detection of bacteria at the level of 10 to the fourth. As you see on the slide, you can see the red indicative of bacteria. On the next picture, you see not only red, but you see cyan indicative of Pseudomonas bacteria. Next slide. So what does proactive wound care look like? So this is a patient, a pressure injury, sacral pressure injury. When you look at that first image, certainly there's some macerated skin, that skin that you're going to want to clean, do some debridement. But looking at that image, you would not have a high suspicion clinically of significant colonization or infection. What you see on the next picture is the initial scan, which shows marked fluorescence. So this is then treated with cleansing, debridement. Even after cleansing and debridement, there was still significant fluorescence. So this is a patient in our clinic. We would then go ahead and, in addition to the antibacterial dressing, we would add antibiotics. And then you can see the progression, loss of the fluorescent, the bacteria, and progression on to healing. Next slide. So the question becomes, when do we initiate antibiotics? We're in the process of reporting a series. In essence, what we look for when we're making that decision about whether to just treat the bacterial burden topically or add antibiotics is spread of that bacteria in an irregular pattern and a significant pattern outside of the margin of the wound. If we can't clear that with cleansing, clear that with debridement, then we elect to add antibiotics at that point in time. The counter to that is if a scan does not show spread into the surrounding tissue, that is not a patient that we would place on antibiotics. Next slide. So again, the first picture here shows the ability to take an image. You can do measurements of the wound. The scanning device has a very interesting capability. For each patient, when you scan, you can start a file for that patient. And then subsequently, when that patient returns for additional scans, you put the images back into that file. So it's very easy to review that file and see the sequence of events, track healing or track clearance of bacteria. So here you see pre-debridement, post-debridement. There's still some bacteria outside the margin of the wound. So that's a patient we would err on the side of adding antibiotics in addition to antibacterial dressings. Next slide. One of the things that's very important, in addition to giving us information that can guide the therapy that we elect, it can also help us not doing certain kinds of therapy. For example, if we have a wound that we're considering the use of biologic tissue, if we have bacteria, we, through cleansing, debridement, and sometimes antibiotics, we would like to see that bacteria cleared prior to the use of biologic tissue. Uh, and then we can see what would occur onto healing of that wound. Next slide. This is an article that was just published last month. I was fortunate to be one of the authors. So we know now that we can scan for bacteria, so we have the ability to scan those wounds and detect greater than 10 to the fourth bacteria. The question becomes, number one, what patients do we scan? And number two, what do we do with the information that we obtain with that scan? So this is a flow chart that's part of that paper that gives some guidance in patient flow with use of the MolecuLight scanner. So after a history of physical, clinical assessment, then an image is taken, the wound, the room is darkened, and a fluorescence scan is obtained. If that's normal, then we would proceed on with standard of care. That being said, that's important information, the fact that there is not uh, greater than 10 to the fourth bacteria. You may elect, for example, not to use uh, antibacterial dressing. So maybe some stewardship with antibacterial dressing. If it's positive, then what we would do is cleanse that wound, rescan it. Again, that takes only a minute or less. Rescan that to see if it's cleared just with cleansing. If not, and there's still a fluorescence in the wound, we can use that scan to guide our debridement. So we know where the bacteria is in that wound, and we can then debride that area, rescan, and make sure that through cleansing and debridement that we've removed the bacteria in that wound. So the goal is to use that scan to identify the bacteria, but then to use the scan to document that through cleansing and debridement that we've removed the bacteria. Uh, if the bacteria can't be removed, then that information is also helpful. It would help us decide on the type of dressing and, for example, the frequency of return in patients that still have a positive scan. As I mentioned before, if the bacteria extends out of the margin of the wound into the surrounding tissue, and that is not cleared with cleansing, then that's a patient many times we would add antibiotics, or we would see more frequently, or be more aggressive with the type of antibacterial dressing. When the scan is normal, then again, you can proceed on with more advanced therapy. So it's important that information is important, not only with biologics, but things like total contact casts, skin grafts, any kind of surgical procedure. Next slide. So what does this really look like from a clinical perspective? So patients are scanned with every visit if they meet the criteria as recently published in our paper. That allows us to identify the bacteria very early before it's clinically evident, and then through cleansing that wound and debridement, we can remove that bacterial burden. It allows point of care, immediate decision making. Uh, and then by removing the bacteria, we would expect more rapid healing, as we've seen clinically, and also prevent the progression of that bacterial burden into more serious uh, complications. For us, this has really been a game changer. Uh, in our wound care clinic and our limb preservation initiative. Thank you for the privilege of presenting this data.
Thank you so much, Dr. Anderson. We've got some really great questions that have come in the chat. So thanks very much. And the first is about antibiotic prescribing and the importance surrounding stewardship, which I know you're trying to implement with this device and using some source control methods. So do you try topical antibiotics for several days or a week to address the bioburden or biofilm before you would switch to oral? And also, do you culture the wound before you would prescribe the antibiotics?
So if the bacteria are in the wound alone, even if we can't clear that with cleansing or debridement, then we would use topical antibacterial dressings. If the bacteria extend into the surrounding tissue, then that's where we would consider antibiotic. I think this allows us to be more selective, knowing where the bacteria are, knowing whether first of all there are bacteria there or not, knowing where they are, and knowing whether or not we've been able to clear them, so that when we do use antibiotics, it's for very specific reasons. So I think that does indeed contribute to antibiotic stewardship.
Excellent. A second question, how do you manage the fluorescence imaging for detection of deep bacterial burden, for example, in a cavity or undermining?
Sometimes we're surprised. I'm fortunate to have some excellent nurses that work as part of our team, but they love the scanner. They refer to it as their baby. But many times when we have undermining or callus of interest, we'll scan, and if you can see the bacteria, that's great. But sometimes after we debride or after we're able to get better visualization of that tunneling, then we can actually see the bacteria. It's important with deep tunneling. Certainly, there may be bacteria in that tunnel that we can't see with the MolecuLight. In addition to that, if there's no wound and a patient just comes in with cellulitis, cellulitis alone many times is not picked up with the MolecuLight. It's when that bacteria extends out from the margins of a wound that you're able to see it with the MolecuLight.
So very important, as you say, that this is part of the total package of standard of care and standard assessment. It's not an isolated decision-making tool. I have one more question. What's been the reaction from your patients when you scan them?
That is just an excellent question. Not only important from the standpoint that our patients know what we're doing. We show them the scan many times. They're able then to understand why more debridement is needed. They understand why we're starting antibiotics. And they're looking forward then to the follow-up where they can see the next scan to see if we've made progress. And as I mentioned, we create patient folders in the scanner, and it's very easy for us to just thumb through that. They can see where they started. They can see where the progression of their wound and where they are on that particular clinic day. I personally think that it supports not only patient involvement, but I think patients are more likely to be adherent or follow the physician's instructions.
Okay, and one last question is about the length of time that this takes. I know that you have a limited amount of time with your patients. So is this impeding your workflow or adding a substantial amount of time onto your workflow?
No, I don't believe it is. It focuses many times what we do. So instead of kind of a blind debridement, we can make sure that we're debriding that part of the wound to the level that we can get rid of the bacteria. So it helps us make decisions on the go. But The scan itself takes very little time and it does not really impede the flow of patients in our clinic.
Okay. And there's one more question that's come in that I'll actually take, and it's asking about whether the scans can be included in patient charts, and I assume they're referring to EMR. So all of these images can be easily exported off the device, and it is EMR compatible with most of the major EMRs. For example, it's part of the Epic app orchard, so it links up closely with Epic and allows easy transfer. So thank you so much, Dr. Anderson. Greatly appreciate your time and educating us on how you're doing this unique approach to proactive wound care. Thank you so much.
Thank you.
Okay. Thanks, everyone. And if you have any, please make sure to pop by the MolecuLight booth with any additional questions that you might have. There's a team there and some resources, and we'd be happy to speak with you. Thanks very much for attending.